Welcome to Oh My God exam, sickle cell anemia, class 9. All of us know that there is a basic substitution of valine for glutamic acid in the sixth position of the hemoglobin chain. But what happens is there is a hemoglobin polymer that is being formed. These polymers are insoluble and they are all being parallelly arranged. As a result of which, you find that the RBC itself gets elongated and it becomes slightly curvilinear, called the hammock shape or the sickle shape. That is what we people are seeing in this diagram. I would like you people to draw this, courtesy Mayo. In the meantime, the sickle cell, what happens is it obstructs the blood vessels, leading to vaso-occlusion. This is a peripheral smear of a sickle cell anemia. The hemoglobin is reduced from 9 to as low as 3 grams per deciliter. The RBCs are normocytic, normochromic, not micro or macro. There can be a good number of target cells. Target means you have got a dot of hemoglobin in the center as well as periphery. There can be the precipitation of the sickle cells. As I told you, there can be some purplish, slightly larger cells, the reticulocytes, that can be present. WBCs and platelets are not affected. The reticulocyte count is increased because it is a hemolytic anemia. So also serum bilirubin because of hemolysis. This is an important flow diagram in pathogenesis. There is the arterial oxygen and the hemoglobin S is soluble in it. But when there is a stasis, you find that there can be polymerization. And also there can be the damage because of the influx of calcium and leakage of potassium. All this leads to the formation of a stiff, viscous sickle cell, leading to capillary occlusion, and the survival is also reduced. There can be an anemia, leg ulcer, jaundice, and also infarction of the organ where the blood supply is affected. The electron microscopy I have already mentioned. And the factors affecting sickling will be mainly the percentage of the hemoglobin S, and it is being prevented by means of hemoglobin A. Sometimes it can occur in combination with hemoglobin C and T. This is a very important question, the vaso-occlusive crisis. So, what are all the crises in sickle cell anemia? One is vaso-occlusive, hand-foot syndrome. You find that there can be, particularly the cortical bones, there is a obstruction and a thinning. Bone and joint crisis. It can occur in larger bones also, leading to necrosis. Abdominal crisis because of infarction in the mesentery or the visceral organs. CNS, there can be hypoxic necrosis. And there can also be a pulmonary crisis. All this vaso-occlusive crisis you must mention. The second one will be hematological crisis. Repeatedly after hemolysis, there is a formation of RBC, but it gets burnt out, and this is called aplastic crisis. Megaloblastic crisis due to folate deficiency subsequently. And hemolytic crisis when the red cell destruction is very severe, can be associated with G6PD. Splenic sequestration. Repeatedly there is infarction of the spleen, and there can be something called autosplenectomy. Infections with staphylococcal pneumoniae will be paramount. Other complications are cholelithiasis, autosplenectomy, chronic leg ulcers. This is given as a history, jaundice and stroke. So the crisis for sickle cell anemia, extremely important. So this is the pathogenesis. The genetics have already been mentioned, and the splenic sinusoids, there is sickling, there is occlusion, and there is a hemolysis that occurs. The cells become irreversibly sickled, and as a result of which there is no opening or the patency of the lumen. But sometimes they can be reversibly sickled also. So all this can lead to a destruction of the RBC, reversibly sickled and irreversibly sickled. And these are all the various complications that can occur in sickle cell anemia. Retinopathy, cardiac failure, polylithiasis, renal infarcts, pulmonary infarct, cerebral infarct, any of the infarct of the extremities, aplasia, vasoocclusion, leg ulcers. Leg ulcers, classical history. It can be diagnosed by means of the hemoglobin electrophoresis, wherein the hemoglobin S is getting separated. So this will be what we will have to write. The hemoglobin initially it is mildly reduced, but later on it can be severe. The lifespan is reduced to 2 days. Normally it's about 120 days in the irreversibly sickle cells. All jolly bodies can be seen, target cells can be present, nucleated RBCs 10 to 20%, massively increased. What are the other investigations you can do in sickle cell anemia? One is a slide test with Vaseline, there is deoxygenation and sickling. Second one is reduction by means of sodium dithionate or sodium metabisulfite. Both of these are important. Hemoglobin electrophoresis, I have already mentioned. Hemoglobin F estimation because it is protective. And chorionic villus biopsy in order to have a genetic counseling before the delivery. And there can be other disorders also which will have to be ruled out, such as thalassemia. So investigations means blood picture, other investigations all put together. Thank you.